Dr. Geeta, an executive committee of Chennai Menopause Society, is very happy to invite you all for this webinar, which is conducted by the Chennai Menopause Society and the Vijayawada Menopause Society. It is on bone health. And let's start with the Tamil Thai வாழ்த்து. Midlife prayer. We pray to God to give us grace to accept the midlife physical changes and gently renew our strength. Guide our heart, our mind, and body to navigate the way and our trust in you to lead us safely through. We pray for midlife and mature women who cherish the fond memories of their lives, and also for those sitting in a doctor's office and who are in bed asking for a healing touch. On this day, may all the midlife and the menopausal women have the gift of joy, hope, and good health. Thank you, God, for the promise of hope you hold out to all the midlife and menopause women and inspire us to give this gift of hope to others. Thank you. The lighting of the Kuttuvelakku. Welcome address by our dear President of Chennai Menopause Society, Dr. Hepzibah N. Kribamani.
Am I audible? Good evening, yes, to one and all. Very good evening to one and all. It's my proud privilege on behalf of Chennai Menopause Society and Vijayawada Menopause Society and my own behalf. And I welcome you one and all. I deemed it my privilege to welcome Dr. Shobna IMS President. Madam is doing a lot of webinar, and she through her President webinar, we learned a lot of different aspects of menopause. Okay, so I welcome you, Madam. And she is very much interested in taking care of 70 plus. And that also has stimulated everyone in the IMS Society to visit and go and greet them and cheer them. That's a very good initiative was done by our President, Madam. I welcome you, Madam. It is my privilege to welcome Hara, sir, who is always very friendly. And he's a great vaginal surgeon and endoscopic surgeon and past president of Indian Menopause Society. I welcome you, sir. I feel happy Dr. Jignesh will be joining shortly. He's in the midst of the surgery. I welcome sir also. Who is also a past president, and he did really a wonderful job during the COVID period. Did not stop him to disseminate the scientific knowledge to throughout India. That was a wonderful period. We really enjoyed different aspects also we done. And I welcome Madam Ramadevi, Madam. She's a great academician. She's a founder, president of the Vijayawada Menopause Society. When we asked her, shall we do something? She readily accepted, and I welcome Secretary Dr. Susila. She's very keen on all this activities, and I welcome eminent speakers and an youngster, Dr. Divya Ravikumar. She's actually a menopause certified person. She always take interest. Her this thing is fetal medicine, but this spectrum also she's very much keen. I welcome Divya Ravikumar, and I welcome the Prasanna Madam. And I'm sure at the end of this webinar, people will be going to benefit, because bone health is very, very important. It's a silent killer. We have to know when to treat, whom to treat, how to treat. I'm sure at the end of the seminar, each and everyone will know how to do in day-to-day practice, risk assessment, and how to predict and detect and treat the osteoporosis. Once again, last but not least, I welcome all the delegates who have joined, and welcome each one of you. Over to you, Geeta.
Thank you, ma'am. I would like to introduce the chief guest.
Introduce
Yes,
Dr. Hara, sir. Madam will speak at the end. The chief guest will speak at the end.
Okay, okay. I'm happy to.
Hara, sir.
Can you just put the CV of Hara, sir?
Hara, sir.
I think
Dr. Hara Patnaik, the senior obstetric and gynecologist from Odisha.
Thank you, madam. I think that will do.
Let her introduce.
Okay, madam.
He was the president of Indian Menopause Society in 2015-16, and he's the national coordinator of the Foxy Journal. He's the chairperson Geriatric Gynecology Committee, and very happy to have you, sir.
Yes, madam. I am really happy, because first of all, let me thank Dr. Hepsiba for informing and inviting me to this program. And this is a unique program, a joint program of Andhra Pradesh and Tamil Nadu. Chennai chapter president Dr. Hepsiba with Vijayawada, the capital city, I suppose, the next capital city of Andhra Pradesh, Dr. Susila. Both the presidents have joined hands to have this
Sir, it is Dr. Ramadevi, President Dr. Ramadevi.
Whatever it has been written, it is written. And I will like to specially say great thing about Madam Ramadevi, because if you think of gynecology in Vijayawada, it is Ramadevi, Dr. Ramadevi, and Dr. Ramadevi only. Whoever has visited Vijayawada must visit Dr. Ramadevi. So I visited her once in her house. At this age also, she is very active and very, very loving, caring. Madam Ramadevi, if you are there, I went to her hospital and home, which is together. And Madam is so happy to welcome us there. And nothing happens in Vijayawada when Ramadevi Madam is there. So, Madam Susila, thank you very much. And I know, Dr. Somna Mohandas, the president of this year, my dear friend, and she has taken this mission, putting IMS in the forefront and stimulating all of us for all academic program, which we are very, very proud of. Then the legacy started with Dr. Ambuja, the immediate past president, Madam Namaskar, and She was really, really wonderful and very good to all of us. My dear friend, Dr. Jignesh will come and join very shortly. As I hear the program, today's webinar is on bone health and in menopause, which is a very vital and important subject to discuss and learned by the. Yes, madam. Yes, to be learned by menopause practitioner as well as the elite patients themselves. The elderly women are suffering from osteoporosis. So today the program, Madam Hepzibah, you have structured in such a nice way that we will be discussing pathophysiology, then risk assessment, then fall prevention, finally the management of postmenopausal osteoporosis. I think we will all learn a lot from this program, and I thank you very much for inviting me and giving an opportunity to meet you all here. Thank you very much. Namaskar.
I'd like to introduce the next guest of honor, Dr. Ambuja ma'am. Dr. Ambuja was a past president of Chennai Menopause Society 2021 to 2022. And she's a retired professor and HOD of Obstetrics and Gynecology Department, Osmania Medical.
I am familiar with Chennai and Vijayawada Menopause Society. I think there's no need to talk much because you introduced me as the president. That's enough.
Thank you, ma'am. We are happy to have you, ma'am.
Thank you. Thank you. Me too. Very happy to participate in this seminar because I always think Chennai is my mother's place always. It is Maika. And Vijayawada is very close to me. And me and Susila with Ramadevi madam, we are working together for so many things. Really happy that Chennai and Vijayawada both together working so comfortably with all the things. And Harabhai, it's very nice to see you after a long time. Because after this seminars, we are not meeting physical. I don't know whether you are coming to Jaipur.
Yeah, I am going on 23rd evening. My flight will reach at 8:30 p.m.
Yeah, it's nice. We all will have a gala time at Jaipur. And what to tell about Shobna? This is her dream project, I'll tell you, because 70 plus she has chosen. With all broken bones and all, people will come. How to take care of them. Really, it is very good project that is there. And I'll tell you this bone health, we are talking n number of times. But still every day something new is coming for our health, and still the problems of women are not solved. Sometimes men also. Broken bones, how to take care of them. These are all the major problems that are there, not able to do much. Recently, I heard one of the medical representative came and told this one they are going to release denosumab, that injection every month they can take it in the outpatient, and that's going to be really a boon to all the elderly people. We should wait and see how it is going to be, because all the trials are being, human trials are also being done, and it's going to give very good result. And it's a good news for us that if something is given to the old people, it is like a boost for all of them, and it is a gift. And at this point of time, it is a needed seminar. Shobna, what you have chosen is really good. And thanks to both Ramadevi madam, Hepzibah madam, and Susila for making me a part of this seminar and involving me to be the guest of honor. Thank you very much.
Thank you, ma'am. Can I introduce Dr. Jignesh?
Yes, I think he has not joined yet.
Joined. He is in the midst of Suzanne's section. He said he will join little later.
Okay,
we just go on to the scientific session. And can I have Dr. Rama madam's CV? Can you project some Rama Madam's CV? Yes. It's my privilege to introduce Dr. Rama Devi Madam. She is a founder president of Vijayawada Menopause Society. She has worked as professor of OBGYN in Siddhartha Medical College, Vijayawada. She is principal SMC Vijayawada, past president of Vijayawada OBGYN Society. She has been elected for many times. That means how so much service she has done. It shows that. She has organized many workshops, CME programs. She is an organizing chairperson for APCOG 2006 and 2015. She is a member of organizing committee of UFOX South Zone Vijayawada. I welcome you, madam. Can I have Dr. Shanti's CV? Dr. Shanti?
I think one more word we need to tell about Rama Devi Madam.
Yes, madam. Please
She
add,
was
madam.
the director of combined state of Andhra Pradesh and NTR University for Health Sciences.
Okay.
And at that point of time, she did lot of things to the gynecology department all over the Andhra Pradesh, both Telangana and Andhra Pradesh that was there. And she was the pillar of all the activities that was happened, and she sanctioned many things. And she was very, very helpful to all the gynecologists in that period.
So we
Thank you, Rama Devi Madam.
We have an IMS, all this administrative people. Sir also, he was a director of primary health center.
No. Being the administrative post,
it is
so
very
many
useful
people.
for us. It's very easy
Yeah.
to approach
Thank you.
them and get things done, madam.
Thank you.
When they are there in the seat, it's very easy for us, and it is so
that's
useful for the entire state. Welcome you, madam. I'm very happy that you are chairing a session. I welcome my dear friend, Dr. Shanti. He is the past president of OXI and our vice president, Chennai Menopause Society. She is the director of IOG, former HOD of Kiel Park Medical College. She is a project director in the Excellence for Tubal Microsurgery for nearly 6 years and past president of Women Doctor Association. Over to you both, madam.
Thank you, Hepsi. It is indeed a pleasure to be chairing this session along with stalwart Dr. Rama Devi Madam. And all the speakers earlier have stressed upon the importance of identifying osteoporosis and treating the same. So Professor Hepzibah has charted out a nice program where we will start from the basics. So to talk about the pathophysiology of postmenopausal osteoporosis, we have our young, dynamic, Chennai Menopause Society member, Dr. R. Divya, who is actually now pursuing fellowship in fetal medicine in SRMC. She herself is a credentialed Indian Menopause Society practitioner, and her special interest are fetal medicine, ultrasonography, and research. Dr. Divya, please.
Is my screen visible?
Yes. Yes.
Yeah, it is seen, Divya.
Yes. So thank you all mentors for your kind words. I'll move on to the topic proper. Today's pathophysiology of postmenopausal osteoporosis. Osteoporosis is a systemic skeletal disease which is characterized by low bone mass and microarchitectural deterioration of the bone tissue. Why does this happen? Because there is problems associated with bone structure. The quality of the bone drops down as age and menopause progresses, and the bone density, because of the molecular changes, gets affected. So we will be going in through detail regarding why these things happen and how these things have to be kept in mind while prescribing prescriptions for our patients. So the WHO has defined osteoporosis as a T-score of less or equal to 2.5, and Tinea has a T-score between 1.0 and 2.5. Femoral neck and lumbar spines are the recommended areas of interest where we can use these scores to categorize patients into osteopenia and osteoporosis. The group further goes on to add that fragility fracture is described as a fracture that is caused by an injury that would be insufficient to cause fracture in a normal bone. Osteoporosis related fractures are most important because they cause long-term morbidity, disability, and mortality. And it is often underdiagnosed and undertreated despite having effective preventive measures and treatment options, which are known both to the patient and to the physician, but unfortunately we are hesitant in starting the treatment thinking of the side effects. So when we understand the pathophysiology correctly and in depth, we will be able to overcome our fallacies and give the best possible outcome for our patients. So regarding the burden of the disease, bone mineral density decreases with age, and thus primary osteoporosis mainly occurs approximately 10 to 15 years after menopause, and in elderly men at around 75 to 80, and if they have any lifestyle factors, probably a little earlier. With an expanding aging population globally, osteoporosis and osteoporosis related fractures are fast becoming an important public health problem that has considerable economic impact on the health services and resources that are to be provided. So moving on to the pathophysiology. Osteoporosis is caused due to multifactorial etiology. It is caused due to problems in peptide hormones, dysregulation in the steroid hormones, environmental factors, as well as genetic factors. So moving on to the main hormone, which is the topic or the crux of today's meeting, estrogen. Estrogen is important for its action on the bone, even during the late menopause period. So how does it act is that it has a direct effect on the bone through the estrogen receptors. It has an indirect effect on the bone by accelerating calcium resorption by the intestines, reducing the calcium excretion through the kidneys, and by regulating hormones such as calcitonin and parathormone, thereby reducing bone resorption. So moving on to the direct mechanism of action on the bone, estrogen acts on the bone cells directly, the osteocytes, the osteoblast, and osteoclasts. The blasts are the cells which maintain the bone formation, and the clasts are the cells which are responsible for bone resorption. Hence, it encourages the blast cells and decreases or reduces the activity of clast cells, thereby helping in maintaining of the bone microarchitecture. Estrogen and androgens, both being steroid hormones, affect both osteoclast and blast function and reduce resorption. So this might be a busy slide, but there are certain key areas wherein we can concentrate regarding the action of estrogen on bone health. Firstly, it has a direct effect on the cytokines released by the T lymphocytes, thereby reducing the action on clast and thereby following activation of the blast cells. In bone remodeling, it starts with activation, resorption, reversal, and formation. Of these, the first three stages are a relatively shorter period, whereas importance or a longer period is held by the bone formation. Hence, it is important that we aim in attaining these osteoblast cells, which are the bone forming cells and which are going to help our microarchitecture importantly. And the estrogen action on the osteoblast stromal cell is also been extensively studied and proved. And it also has a direct effect on the osteoblast because of its mechanical forces initiated by these cells. Now moving on to the other organs, though estrogen do not, postmenopausal osteoporosis is not predominantly affected by these hormones. We need to know why this pathway is important, because these are the alternative medicines which we are going to get when the women presents to us with an acute event such as a fracture. Herein we can see that the cytokines released secrete the rank ligand, which binds with the pre-osteoclast cells and activates the osteoclast cells, which will again go on to the previous mechanism of activation, resorption, reversal, and formation. So we have to keep in mind regarding all the hormones which are going to be incorporated in our treatment protocol, and also the adverse medicines like NSAIDs, which are exploited over the counter while treating our patients with osteoporosis. Now, this is a newer pathway which has been extensively studied in animal models as well as in humans, the bone morphogenic genetic protein 2, which is also indirectly going to stimulate our osteoblast cells. And there are new molecules and genes called as sclerostin, which is extensively studied. And why we have to keep this in mind? Because we are not going to expect the same outcome for all these patients, because when there are going to be mutations in these receptors, then probably our treatment is not going to be such very effective. So moving on to estrogen receptor, we know traditionally there are two types, the alpha and the beta. The alpha type is seen in predominantly all of the bone cells. They have a direct action on the progenitor cells and the multinucleated mature osteoclasts. The osteoclastic activity is for resorption, and indirectly it will stimulate the osteoblastic activity as well. So when there is enhanced expression of cytokines like TNF alpha, interleukin 1, interleukin 6, then there is going to be excessive resorption from the bone, and that bone is going to be fragile. So moving on to the other aspect, though when you have a genetic mutation or a predisposition in your familial tree, you are going to be susceptible for osteoporosis much earlier. Now, lot of work has been done to see whether these gene polymorphism is responsible for the treatment outcome as well. So bone mineral density, bone turnover, and geometry are all highly inheritable, and this inheritance pattern is extensively studied in case of familial hip fractures. And gene polymorphism also affects the response to our treatment. Some of the commonly seen gene polymorphisms are seen in these receptor models: the low density lipoprotein receptor related protein 5, the sclerostin, estrogen receptor type 1, the rank pathway and the rank ligand pathway genes, and also the famous osteoprotein OPG gene. So we have to stress upon the environmental factors, because this is the only modifiable factor probably which will be available when we see our patients. Attainment of optimal peak bone mass is a must and plays a very important role in prevention of osteoporosis. Bone mass accretion starts from childhood and continues into adulthood. Peak bone mass is achieved in the mid-20s for the spine and the hip, and for the other bones such as the radius, it reaches around 40 years. And after that, the bone mass normally declines. And why is it very important to know these timelines is that this is when you have to stress in the importance of our isometric and isotonic exercises and proper lifestyle and dietary supplements, so that we can optimize the peak bone mass before the lady even enters into midlife. So maximum peak bone mass is obtained by adequate dietary intake of nutrients, especially calcium and vitamin D. And in a country like ours, though being a tropical country, we see a lot of women having vitamin D deficiency even during their pregnancy, which is the peak time wherein we expect the bone mass to be at its height. So dietary supplementation and exercises should be reiterated in every visit, and limiting certain lifestyle activities like smoking and having a normal pubertal transition should also be emphasized. And they say that maintenance of regular menstrual function after menarche is also important for obtaining a good peak bone mass. So moving on to the proper postmenopausal osteoporosis, there are two phases in bone loss in a lady's life after midlife. One is going to be because of menopause, and one is going to be because of aging. Aging, in the sense, it is going to be similar, or the factors are going to be similar, like the male counterpart. But menopause is going to be unique. So what happens here is predominantly the trabecular bone starts to weaken because of the estrogen deficiency. And this phase is going to last for about 4 to 5 years after she attains menopause, and 4 to 5 years after she attains menopause. And aging is going to happen much later, the second phase, wherein there is going to be loss of both trabecular and cortical bone. And this is similar to what is going to happen in the male counterpart. So during the menopausal transition, they say that there is going to be an average reduction in the bone mineral density at about 10%. And approximately half of the women are losing bone even more rapidly in those 5 to 6 years around menopause. And 25% of postmenopausal women are classified as fast bone losers. And it is important that we pick up these women, measure the bone loss early and the resorption markers, so that we can give proper treatment and identify them before they go into the problem of fractures. So these are my references. Mainly the guidelines taken are from the International Menopause Society guidelines of 2003. And hope I have done that justice. And I would like to thank Hepzibah Madam for giving this opportunity, as well as for the CMS team. Thank you.
Thank you, Dr. Divya, for your wonderful elucidation of pathophysiology of postmenopausal osteoporosis. You have laid the basics now. And
Shanti ma'am, there is a small change, ma'am. I would like to introduce the president, and then after her address, we will continue with the scientific session.
Okay, okay.
Please show Dr. Mohana, Dr. Shobna Mohandas slide, please. CV. We are very happy to have Dr. Shobna Mohandas, the Chief Consultant Gynecologist, Laparoscopic Surgeon, Sun Medical Center, Thrissur, Kerala, and the President of Chennai Menopause of Indian Menopause Society. She is the chairperson, Women Doctor Wing, IMA Thrissur, President and Mission Pink Health, IMA Thrissur, past President, General Secretary, and the Website Committee Chair, Quiz Chair, IMS. She has authored 2 books in gynecology and contributed chapters to several textbooks. And she is an invited speaker at more than 200 venues. Over to you, ma'am, for your guest lecture, ma'am. Thank you, President's lecture, ma'am. Thank you. Shobna, ma'am.
Geeta ma'am, ma'am has disconnected, I guess. Shobna ma'am.
Yeah. Dr. Hepzibah ma'am is like calling her. So.
She's joining.
Ma'am, in meantime, Dr. Ramadevi will talk. Dr. Geeta.
Oh,
yeah.
Ma'am, I think
Hello.
she's joining, ma'am. Good evening, Dr. Shobana, ma'am. Sorry, we somehow just pushed on quickly, and we're very happy to have you as our president. And kindly give your valuable address, ma'am. Can you put the CV, Shobana?
No. Please do not go read out my CV. I'm happy that Chennai Society and Vijayawada Society, and especially my dancer-sized friend from Vijayawada, Dr. Rama Devi is also there here, and that all of you are working together to improve the bone health of the women of the country. And even in small crowds, when you keep on and on and on talking about it, it becomes, a small little corona that started in Trishur reached all over the country. Similarly, when you go on talking, having webinars about bone health all over the country, by and by, all of us will start looking after our health and looking after our own people's health. And I hope this goes on and on and on. I'm not feeling well today. I was wondering whether to join actually. Then I thought it would be easier to join than contact Hepzibah, and then I came and joined, And I have to prepare for stem cell therapy day after tomorrow. I have not finished that either. So wish you all the best for this webinar, Dr. Hepzibah, Dr. Rama Devi, Dr. My dear friend Vijayawada, Sushila, whom we met in the airport.
Yeah, thank you, ma'am.
Shanti, Tarabai, and everybody. All the best.
Thank you.
Thank you very much, ma'am.
Thank you. Thank you so much.
Thank you, ma'am.
Now, shall we go on to the next talk?
Yes, ma'am, we shall continue.
Which will be by our dynamic president, Professor Hepzibah Kripamani. Can you, Professor Hepzibah has, he's an avid collector of degrees and awards. See, that can be evidenced by the degrees which follow her name. And she is our dynamic president of Chennai Menopause Society, past president OPSI, and
I think you can skip now.
Yeah, and the most important thing is she has written textbooks, and she has developed apps which are really very helpful to menopausal women and for doctors to practitioners of menopause, and directed 2 short films for menopause awareness. So truly a menopause practitioner to the core. So I invite Professor Hepzibah to talk on risk assessment.
Able to see my slide?
Yes, ma'am.
I'm audible?
Yes, ma'am, you're audible.
Right. The topic given to me is the fracture risk assessment in peri and postmenopausal women. So few questions came to my mind. What is the risk assessment? Why should we assess risk? Does it require any special skill? How to categorize for risk of the disease? What are the stages in risk management? What are the strategy to reduce risk? So midlife is the ideal time to look after our health and ideal time to assess health risks so that they can enjoy quality of health later. and it serves as an important preparation for the later part of life. And we all know 1/3 of life is spent postmenopausally, and menopause transition and the time afterwards are important for risk assessment and its prevention so that each woman can enjoy maximum health later on. So to estimate the risk of disease in apparently healthy asymptomatic individuals is based upon assessment of multiple variables. No single risk model is appropriate for all patients and doesn't require any special skills or a complicated technique. It is only a numerical estimate which is made of the probability. So as we all know, osteoporosis is asymptomatic. Unless a fracture occurs, we will not be able to realize it is a silent killer. So why should we assess? For asymptomatic women, it is an opportunity screening for women above 40 years. To diagnose fracture risk, it is by BMD. For treatment purpose, combination of BMD with clinical risk factors provides a better estimate of subsequent fracture risk. And we simply should not treat the T-score alone, but must take patient's full clinical status into account when he makes therapeutic decision. So this was already mentioned, which is a modifiable risk factor, non-modifiable, and environmental. This is a very important thing. We should educate them about nutrition, physical activity, exposure to light, and relevance of risk falling, which is very important to counsel them. So why should that stages? We should identify, we should evaluate the associated risk. Then we have to control, not only to treat the disease, we have to control the risk also. So it is usually classified as a high when the certain, it is with certainty it is going to harm. When it is medium, when harm will often occur, low is seldom occur. This is how they are classified. So there are, apart from this, the clinical examination itself gives a clue that they are having some problems. Loss of height, look for, so when we do a clinical examination, we have to look for kyphosis, and the hump may be a sign of vertebral fracture. So the occiput to wall distance in tan position, inability to touch implies thoracic fracture. Actually, women can lose up to 1 to 1.5 inches to be measured annually in postmenopause. Loss of 1.5 inches or more calls for evaluation by lateral thoracolumbar radiography or DEXA. Another important clinical examination is the inability to insinuate 4 fingers of hand between lower rib cage and anterior superior iliac crest implies lumbar fracture. These are clinical assessment. So there are tools are available for fracture risk assessment. One is ASTA, the FRAC score, the WHO fracture risk assessment, and a Midlife and Beyond app, which is available in Google Play Store. So the OSTA is developed by WHO. It's a tool based simply on age and body weight to identify who are all at risk of osteoporosis. It's a simple formula, body weight minus age in years into 2.2. It's a ready chart. You can keep it in your table. So this is the chart. So the age is 44 and her weight is 61 kg. So she comes under low risk. It's very easy to, okay. So this requires a online tool where you have to document everything. You have to include the age, date of birth, and weight, height, previous fracture, smoking. All the risk factors are enumerated here. And even without BMD, with BMD, it will calculate the risk, major osteoporotic risk and a hip fracture within next 10 years. And the output is usually in the percentage and indicate the risk. Score refers the level at hip, arm, and spine. So, this? Okay. So in addition, we are supposed to assess the sarcopenia. There is a scale for a sarcopenia, the strength, assistance in walking, rise from chair, and all this is rated, and you can assess the sarcopenia because it is a skeletal-muscular health, which is we are talking. Actually, the tool I just wanted to show you, it is not away, it is not in the. 1 minute. Is it seen? Okay.
See your thing.
This thing is gone. It's able to see.
Now it has come back.
Yeah.
So in addition to this flask, these both, this VOSTA and ASTA and the FRAN score, you can download this Google form in the Google Store, Play Store, and you can do it in app which is created by us. You can assess both this VOSTA fracture and this sarcopenia can be assessed. So there are few indications for DEXA also. All postmenopausal women more than 5 years, we should do DEXA. Postmenopausal women less than 5 years of menopause with risk factors. When the patient is on rheumatoid arthritis, the patient is on corticosteroids, women in menopause transition with secondary causes, radiological evidence of osteopenia and presence of vertebral compression, we should assess the DEXA also. So this is the app I was talking to you. You can download, go to Play Store, Google Play Store, you can download it. It is called Midlife and Beyond. See, you can very easily, you put all this basic age and the height and other things. So when you put the age, it automatically says if it is 49 years and 70 kg, it shows low risk. Similarly, FRAX can be assessed. All the relevant thing you have to feed in. It is in your fingertips. You can add age, all those relevant details. If you add, it will show the risk. So you can ask your patients to go and get it done, or the secretary, she can do it, so that will show the major osteoporosis or a fixed fracture. And sarcopenia scale also is there in the app. So all that based on the history, you can load it and it shows whether it's a high or low, and you can generate the report also. This is very handy app which can be used by everyone. So what can we do after assessing the risk? We should teach them lifestyle modification. We should encourage them to take calcium, vitamin D. If it is severe, we have to give them an appropriate medical therapy. If they have a menopausal symptom, it can be combined with menopausal hormone therapy. We should tell them fall prevention strategy. Simple thing, they have to hold on and come down. Like that, we can teach them. So what are the value? It is the best strategy. If you know some risk, we can teach them, and it is the best strategy for prevention. It improves the overall quality of care, encourage awareness, the patient-doctor relationship improves, the trust improves, misconception is dismissed, always the unwanted fears are removed, provide the basics for discussion. So the risk assessment in peri and postmenopause, which is a very potential tool to prevent morbidity and mortality due to fracture. The prevention is our duty, so we have to do it. And then all women in all age group are axle around the women whom the family, the society, the whole universe is revolving. So the health is very, very important at all stages of life, and more so in midlife and beyond. So thank you for patient listening.
Thank you, Hepsi, for your clear talk. Now I hand over the podium to my esteemed co-chairperson, Madam. Okay, Rama Devi, Madam. Madam, you can.
Thank you. Thank you. At the outset, I thank the Chennai Society and the Vijayawada Society, both of them combination. I'm very happy to be associated with the Chennai Menopausal Society. And I thank Dr. Shobna Mohandas, and very happy to see Dr. Ambuja Garu, Dr. Patnaik Garu, and Dr. Jignesh are not yet joined, past presidents, and all the speakers and everybody. Very good evening to all of you. Now I want to introduce next to her, Dr. Hema. Dr. Hema Prasanna, very happy to introduce. She is a consultant obstetrician, gynecologist, laparoscopic surgeon, Ankura Hospital for Mother and Child, Vijayawada. Graduated from Katuri Medical College, Guntur. Post-graduation from Kasturba Medical College, Manipal University, 2013. Senior residency, GGH, SMC, Vijayawada. Fellowship in laparoscopy from Association of Minimal Access Surgeons of India. Basic and advanced laparoscopy, hysteroscopy training. She underwent all the trainings. And previous positions, resident and at Sri Ram Hospital, assistant professor and NRI Medical College, consultant at Andhra Hospital, Vijayawada. Awards. Eminent Memorial Award for the Best Outgoing Student, MS OBGY, 2013, Manipal University. Dr. A. Padmarao Memorial Award for the Best Resident in OBGY, that is between 2010 and 2013. Talks and publications, oral paper, poster presentations and talks in lineal meets, state conference and public awareness talks in media. Areas of interest, high risk obstetrics and endoscopy. She is going to talk on fall prevention in postmenopausal women due to osteopenia or osteoporosis. She's come on.
Yes, ma'am.
Hand over.
A very good evening, one and all. Thank you, ma'am, for your kind introduction. At the outset, I would like to thank Dr. Rama Devi, ma'am, and Dr. Cecilia, ma'am, for giving me this opportunity today. Coming to today's topic is on fall prevention. In the next 15 minutes, I'll be discussing this topic under the following subheadings. After a brief introduction, definition, risk factors of fall, interventions, and a small take-home message. Coming to introduction, aging is an irreversible normal phenomena that takes place at a molecular level, reflecting not only physically, but also functionally and psychosocially. Falls are one of the common problems in elderly that cause significant increase in morbidity and mortality among elderly population.
Slides are not changing, Hima.
Ma'am, I'm still in the first slide, ma'am.
Okay. Sorry.
And fall-related injury is the second leading cause of unintentional injury, accounting for about 11% of unintentional injury-related mortality rate globally. India being the second most populated country in the world, and its number of older adults is estimated to be around 137 million in 2021. And this seems to increase to around 198 million by 2030. So due to this demographic transition in India, it has led to absolute increase in the older adult population, which in turn increases the demand on healthcare system to add the quality of life to the years lived. According to WHO Global Report on Falls Prevention, people aged 65 years and above fall.
You are not able to see your slides.
You're not able to see, ma'am?
No, not able to see your slides.
It's not moving.
Kindly reshare the slides, ma'am, so that
Only your name is seen, that's all.
Oh, okay. Is it seen, ma'am?
Not seen.
No, slides are
Slide.
seen in slideshow
Your
format.
name, your
You have
name
to
and your
change it. You have to change it. Only the first slide is seen.
Okay.
rejoin again.
Rejoin.
One cancel and rejoin. That is slides projection.
Person, can tech person help her?
Yes, ma'am. Ma'am, kindly reshare the slides, ma'am.
Yeah.
Open the PPT, ma'am, and then share the screen.
So osteoporosis is one aspect and fall prevention is another aspect. Both very, very dangerous.
Yes,
Even
ma'am.
sarcopenia.
Ma'am, please don't go to slideshow, ma'am. There is some problem, I guess.
Okay.
Continue with this view, ma'am. Continue with the same view.
Continue with?
It's smaller wide length. Yes, ma'am. Now it's perfect.
It's not moving for me.
Just slide on 2-3 slides. Just move on to.
No, it's not moving for me also now.
Yeah,
now it's
now we
moving,
can
ma'am.
see.
we are able to see, ma'am.
Now,
Yeah. Now it's
We can see
working.
the
ma'am.
slide.
okay, thank you. So, as I said already, aging is a irreversible process which occurs at molecular level, and it is reflected physically, functionally, and psychosocially. So, falls are common among elderly population, and it has a significant increase in the morbidity and mortality. So, these falls are second leading cause of unintentional injury, accounting for around 11% of unintentional injury-related mortality rate globally. India being the second most populated country in the world, its older adult population was estimated to be around 137 million in the year 2021, and it's going to increase to around 198 million by 2030. Due to this demographic transition in India, there is absolute increase in the older adult population, which in turn increases the demand on the healthcare system to add the quality of life to the years lived. According to WHO Global Report on Falls Prevention, people aged 65 years and above, they had a fall rate of around 28 to 35% each year. So the percentage of fall increases with increasing age. In India, the rate of fall is around 31% among adults above the age of 60 years. So 1 in every 10 fall causes serious injury like a hip fracture or head injury. If there is a history of fall, then there is increased recurrence of around 2 to 3 times increased recurrence the next year. Falls are associated with physical pain and emotional pain. They need long-term hospitalization, and they lead to older adults depend on others. Coming to definition, what exactly does a fall mean? Fall means it's an event which results in a person coming to rest unintentionally on the ground or lower level, not as a result of a major intrinsic event such as stroke or overwhelming hazard. Near fall means there is sudden loss of balance with incomplete fall, which includes slips, stumbles, or trips with the ability to control. What does fall leads to? Fall always doesn't lead to a traumatic injury, might lead to a traumatic injury as well. So fall, the injuries following a fall might be ranging from no injury at all. It might lead to a minor injury like an abrasion or bruising, which requires mild analgesics. Moderate injury requiring a suturing or splitting, and it may result in a major injury like a broken bone, which requires a cast or a traction or a surgery, and it might be fatal as well. 80% of the non-vertebral fractures occurs due to falls. What are the risk factors for fall? If we know the risk factors, we will be able to prevent the fall by addressing the risk factors. So, age above 65 years, they are at increased risk of fall. And any previous history of fall, there is increased risk of recurrence again 2 to 3 times. Musculoskeletal and neuromuscular impairment, including osteoporosis, lower limb muscle weakness, decreased grip strength, gait and balance problems. All these things alone account for around 41% of the falls. Then comes impaired visual acuity, hearing loss, use of psychotropic agents, and usage of multiple drugs more than 4 in number, Parkinson's disease, dementia, osteoarthritis of knees, diabetes with peripheral neuropathy, and vitamin D deficiency. Other risk factors for fall include usage of alcohol, sedentary lifestyle, malnutrition, failure to use walking assist devices, unsafe home environment, and unsafe outdoor environment. These two alone account for about 21% of the falls, and socioeconomic factors. So how to prevent fall? Fall prevention, major risk factor being the musculoskeletal and gait and balance problems. So if we address that, if we improve gait and balance and strength and movement, then we are going to prevent nearly 23% rate of falls. So gait and balance training is very important. TIACHU is a Chinese gait balance strength training exercises program, which is very useful for elderly. So meta-analysis of RTCs have shown there is a 23% reduction in the rate of falls with the proper lifestyle changes. Then comes drug history. Drug history needs to be reviewed annually, and the clinician need to de-prescribe the medication, withdrawing psychotropic medication like benzodiazepines, sedatives, antidepressants, and antipsychotics. Visual acuity check need to be done annually. Bifocal glasses are not suitable for walking. So patient need to discuss with their ophthalmologist regarding separate glasses for reading and walking. Then comes a home risk assessment. Home risk assessment and remove home hazards, because this accounts for almost 20% of the falls. So they need to use non-skid floors and tiles and carpets at home. Immediately clean up the spilled liquids, oils, and soap water. Non-slip mats needs to be used in bathtub. Grab bars needs to be used for shower and bathtubs. Raised toilet needs seats with armrests, helps them. So these are the various home hazards that can be addressed to prevent fall. So remove unstable tables, remove tripping hazards from the floor, place colored non-slip strips where floor level changes, remove throw rugs, make sure that the beds and chairs are at lower level so that they can easily access, pad the sharp edges with plastic bumpers, remove furniture in high traffic areas, use handrails on either side of the staircases and hallways. Place night lights in bedrooms, bathrooms, and passages. Use walking stick with non-slippery bottom end. Use proper footwear. Avoid alcohol, and a healthy balanced diet is always a must. And coming to vitamin D supplementation, it's indicated in individuals only those who are at risk of deficiency. We need to check into their dietary intake, whether there is any deficiency in the dietary intake, any history of malabsorption, those who have less sun exposure, those who are obese, those who have slow gait speed, difficulties in raising from chair, and those who have balance problems. They need to be given with a vitamin D supplementation. And the recommended dose is around 800 to 1000 international units daily. Falls are not inevitable. They are preventable. Active lifestyle with some isometric exercises to improve strength, balance, grip, and protect your reflexes. Thorough medical history and complete medical examination annually. Prescription needs to be revised annually. Optimal correction of visual defects and hearing. Home hazards need to be taken care of. This is going to reduce definitely the falls. These are my references. Thank you.
After an excellent presentation by Dr. Hepzibah, wonderful presentation by you, Hema. Very nice presentation. I think no doubts should be there for all the people. After all the good speakers, now we are going to have a vibrant speaker from our society, Dr. Susila Pinnamneni.
Thank you, ma'am.
In the society. So, in Obstetric Society, Vijayawada Obstetric Society, Menopausal Society, everywhere, she is everywhere. We need. So, consultant obstetrician and gynecologist, Lata Super Specialty in Vijayawada. Dr. Susila Pinnamneni, Samata Multi Specialty Hospital, Mangalgiri. 2 hospitals she is running. President Vijayawada Obstetric Society at present, 2022 and 2023. Secretary Vijayawada Menopause Society, member MTP Committee Foxy, organizing secretary first APCOG 2015 and EVA Foxy South Zone 2018. Trainer certificate courses on contraception and clinical practice conduct of the United Nations Population Fund and Public Health Foundation of India. Senior and RSC Master Trainer, speaker in national conferences and author of the chapter Foxy Focus on Aging Gracefully. Awarded first place for best photography of indoor and outdoor plants conducted by Foxy on World Environment Celebration 22. Now I am presenting Dr. Susila, ever smiling, very active, vibrant lady from our society. She is going to talk management of postmenopausal osteoporosis.
Thank you, ma'am, for your kind words. So I'm going to talk on management of postmenopausal osteoporosis. So this is an emerging problem in the geriatric group and also a rising trend in the public health issues. So we need to address them. How do we manage the postmenopausal osteoporosis? So 58-year-old woman who had attained a natural menopause 10 years back had a hip fracture and with no comorbidities, and BMD was done by DEXA, and her T-score was found to be minus 2.8 of standard deviation. So what are the guidelines for this, and where do we put her, whether it is a low risk or high risk, or what are the type of the drugs that is a pharmacotherapy, and how do we prevent the fractures or the morbidity? So she is postmenopausal lady, and the T-score shows her to be an osteoporotic, and also she had a history of hip fracture. So she falls in the high risk group, and universal recommendations or the prescription writing for each and every postmenopausal woman would be calcium and vitamin D supplementation, diet, exercise to stop alcohol and maintain healthy weight. So National Osteoporosis Foundation has given the guidelines for whom we have to start the pharmacotherapy. So hip or a vertebral fracture, which is identified on the radiograph, a T-score of less than 2.5 or less than 2.5 at femoral neck or spine after appropriate evaluation to exclude secondary causes, and a low bone mass, T-score between 1 and 2.5 at the femoral neck or spine, and a 10-year probability of hip fracture of 3% or greater, or 10-year probability of major osteoporotic related fracture of 20% or greater. This is on the FRAC score for Asians. So we need to calculate FACT score for all our postmenopausal ladies, see for the DEXA after 5 years of their menopause, and then start the therapy, or in case of a fracture also we need to start the pharmacotherapy. So in this patient, the treatment options would be, because she's beyond 10 years of menopause, we cannot start her on menopause hormone therapy because we have lost the window of opportunity. So the other pharmacotherapy would be bisphosphonates, denosumab, terapeptide, or the selective estrogen receptor modulator, that is the raloxifene, or the calcitonin. So how do we classify these agents? They are the anti-resorptive agents, that is to decrease the bone resorption, anabolic agents to promote the bone formation, and uncoupling agents to stimulate the formation of bone and act as an anti-resorptives. So the anti-resorptive agents are the bisphosphonates, denosumab, and the raloxifene. The anabolic agents, that is the bone formation agents, are the parathormone hormone analog, that is the teriparatide and abaloparatide. And the uncoupling agent is the denosumab and the romosozumab. So the recommended therapeutic options for postmenopausal osteoporosis. So this depends upon the fragility fracture previously, whether she had, and where do she falls when we categorize the risk. That is whether she falls in the high risk or moderate risk. So two important things are there to recommend therapeutic option. One is whether she had a fracture before, and then what is the risk of fracture. So if she has no prior fragility fracture or moderate fracture risk, then alendronate or denosumab or risendronate or zoledronic acid. So mainly the bisphosphonates are prescribed. If she has a fragility fracture or she falls in a high risk group, then we need to start denosumab or teriparatide, or the only bisphosphonate allowed here is the zoledronic acid. And the bisphosphonates are the first line of the therapy. They suppress the resorption, cannot be used if the glomerular filtration rate is less than 30 or 35. They decrease the vertebral fracture and also the non-vertebral fractures. The reduction is about 50%. So these are very useful. Bisphosphonates can be started even by us, not by only the orthopedicians. And non-vertebral fractures are not prevented by abandonment. We all prescribe Bandron 150 orally every month. So this cannot be prescribed when we have a non-vertebral fracture. And zoledronic acid can be prescribed when we have a vertebral or hip fracture, and these decrease about 70% of vertebral fractures and 41% of the hip fractures. So the main side effects is the gastritis and avascular necrosis of the jaw and atypical fragility fractures or delayed fracture healing. So the bisphosphonates, as we all know, there is two options are there. One is the treatment dose, other is the prevention dose. Whenever we have a high risk case, we have to go for a treatment dose. Whenever we have a low risk for fracture or osteopenia, we can go for a prevention dose. So alendronate, risendronate, and abandronate can be given orally, and these are the commonest drugs used. The main advantage of abandronate, though it is used monthly, but cannot prevent the non-vertebral fractures. So how do we give this? These are oral tablets, should be taken on empty stomach with plain water in the early morning. Nothing can be taken for 30 to 60 minutes after they take the bisphosphonates, and they have to walk about or sit upright for half an hour, and dental examination is a must before we initiate the therapy. And IV solutions at the injections are available in case of abandonate and zoledronic acid. So in case when we start the bisphosphonates, in a period of 5 years, the bone mass density in the lumbar spine increases by about 10%, which is really a good value. And a second option is the teriparatide. This is commonly used in moderate to severe osteoporosis because it stimulates the bone remodeling. It is very expensive, can only be given subcutaneously. It has to be taken daily, and the side effect is the mild hypercalcemia. And as we can give only for 2 years, it cannot be continued for a longer time, and the effect lasts only for 1 more year after we stop it. And the patient whom we cannot give are the multiple myeloma patients, teenagers and children where they have the growing bones. So then comes the denosumab. Denosumab is a humanized monoclonal antibody. So we all know that whenever there is a decrease in estrogen, the rank ligand increases. As the first speaker told Divya, that is the rank ligand increases whenever there is an osteoclastic activity. So the denosumab binds with the rank ligand and hence prevents the osteoclastic activity and inhibits the bone resorption. That is the main role of the denosumab. And denosumab is given 60 milligrams subcutaneously once in 6 months, quite effective, and also it is, we can say it is a proper drug in case of high-risk patients, and also who had fractures. and it reduces the fractures in vertebra by about 68% and hip in about 40%. It is commonly used in the women who take these aromatase inhibitors for breast cancers. It is contraindicated in hypocalcemia, pregnancy, hypersensitivity, and the potential side effects include the avascular necrosis of the jaw, risk of infections, atypical fragility fractures, and suppression of bone turnover. So the next is a calcitonin. Calcitonin is the intranasal salmon calcitonin given in a dosage of 200 IU, and it is mainly indicated when all the others are not, when the woman is not able to tolerate the other drugs. There is a significant reduction in the vertebral fractures, but no effect on the non-vertebral fractures. The important thing is it decreases the vertebral fracture pain. So the selective estrogen receptor modulator is the raloxifene given in 60 milligram orally, decreases vertebral fracture by about 55%, no effect on non-vertebral fractures. It decreases the risk of breast cancer, but the main important thing we have to understand that it has adverse effects like venous thrombosis. There is an increased risk of it, and hot flashes. And in patients who have hot flashes or symptomatic patients, we cannot prescribe raloxifene. At the same time, it increases the coronary artery disease. So there are no definite guidelines as to when or if to repeat DEXA scan with treatment. And generally, DEXA scan should not be repeated within 2 years. And later, if you repeat also, it should be on the same machine. Combination therapy with 2 or more agents are not advocated because they have not shown any benefit. Better is to go with a single therapy. So the Endocrine Society in 2019 has given the recommendations saying treat patients who are at risk, high risk, particularly those with the previous fracture. Consider bisphosphonates as a first-line therapeutic choice for postmenopausal women at high-risk fractures. Reassess the fracture risk after patient has taken for 3 to 5 years. And give a holiday if the woman is at low or moderate risk. If she turns out to be a high risk even after we treat, then we need to shift to anabolic therapy, that is teriparatide. And all women undergoing treatment with osteoporotic therapy, except for the anabolic therapy, that is where hypercalcemia can trigger the fragility fractures, we should stop. We should give calcium and vitamin D. That is only in anabolic therapy we should stop calcium. Monitor the bone mineral density of high-risk individuals with a low BMD every 3 years. So commonly questions what we have is, as I discussed, whether we can start or only the orthopedicians can start. We can as well start the bisphosphonates. And there is a role in low vibration therapy saying that osteoporosis can decrease, and mental stress definitely has an effect on bone health. It decreases the bone health. And second case. So Mrs. X, 52 years, comes with history of severe back pain since 6 months. She's 5 years menopausal, and she's on calcium tablets. She doesn't go for an exercise, or she's not taking vitamin D tablets, and she has no idea about the diet, what she needs to take. So always we need to calculate the fracture risk depending upon the BMD, that is with the DEXA, and also the clinical risk factors. Then only we can estimate the fracture risk. It is not only with the T-score, it is with the FRAX scoring by WHO. We have to put in that score and also the BMD value and consider her for risk assessment. So is this patient to be screened? Yes, she needs to be screened because she is 5 years postmenopausal. Definitely the we have to do the either FRAX scoring or OSTRA scoring, which is easy. So she turned out to be a high risk and osteopenia patient. So this is the risk stratification. This is the OSTRA, which Dr. Hepzibah madam has shown us. So again, the prescription writing is the same, where we need to give the calcium, vitamin D, diet, exercise, which form the pillars of prevention of osteoporosis, and we can start her on the menopausal hormonal therapy. So prevention of one of the indications for MHT, that is menopausal hormone therapy, is prevention of the bone loss in women with high risk fractures. And indications for the hormone therapy are prevention and treatment of osteoporosis in the early postmenopause in symptomatic. We have to be careful, it is symptomatic women, unless there are contraindications. This is a grade A recommendation. Prevents all osteoporotic fractures in high and low risk. That is, the hormone prevents hormones, that is estrogen and progesterone, or estrogen prevents the osteoporotic fractures. So there is an increase in bone mineral density in lumbar spine up to 7.6%, and in the femoral neck up to 4.5% over 3 years, and reduces the risk fracture in spine, hip, and other bones by 33 to 40%. So definitely MHT decreases the risk of fractures by about 40%. So out of 100 patients, when we give definitely 40, we can prevent the fractures. So it should not be started solely for bone protection after 10 years of menopause. So because we have lost the window period, we cannot start after that window of opportunity period. The bone protective effect is lost soon after we stop the hormones. So we all know that estrogen, the doses of estrogen is, what are the estrogens we can give? Conjugated equine estrogen, estradiol, estradiol valerate, and we can also give in the transdermal form. So we all know that the progesterone is can be given with the estrogen and has to be added to for the endometrial cancer prevention. That is, we give the progesterone and dydrogesterone, medroxyprogesterone acetate, and micronized vaginal progesterone or micronized oral progesterone. These three are commonly given. They are lipid friendly. And of late, even the LNG-IUS is being used in most of the Western countries, along with the transdermal estrogen patches. So the standard doses are 0.3 milligrams of conjugated equine estrogen, 1 milligram of either estradiol valerate or 17 beta estradiol, and in case of progesterone, 10 milligrams of dydrogesterone or 5 milligrams of medroxyprogesterone acetate, or micronized progesterone 300 milligrams oral and 200 milligrams vaginal. So in case that is in the early menopause, that is where the uterus is intact, cyclic sequential oral therapy is used. That is, estrogen is used for 1 to 25 days and dydrogesterone or the progesterone is added for the last 10 to 14 days. So in case we can also go for the continuous sequential therapy, where we have this Femostone by Abbott company. It is in a pack where estrogen is in 1 milligram and 10 milligrams of dydrogesterone is given. So in case of premature menopause, usually we go for a low dose oral contraceptives until the natural age of menopause, if not contraindicated. Mainly in case menopause, we need to go for a combined regime, that estrogen and progesterone have to be continued. And then this helps for the endometrial atrophy and also prevents a breakthrough bleeding. So commonly used is the conjugated equine estrogen. We can go for 0.3 milligrams or 0.625, and estradiol valerate with micronized progesterone of 100 milligrams or 200 milligrams. So we need to individualize the treatment. Surgical menopause, where we use only estrogen. Perimenopause, where we have to use a cyclical progesterone or OCPs. Early menopause, less than 12 months, we have to go for more of estrogen and sequential estrogen and progesterone. And in case of late menopause, that is more than 12 months, estrogen plus progesterone in a combined continuous method, or Tebilone can also be used. In case of, as I said, premature menopause, we have to go for a low dose pills until the natural age of menopause. So what is the duration of the use of MHT? MHT can be used in case of premature menopause, I said, up till natural age of menopause. In cases where the uterus is intact, where we use estrogen and progesterone, it is 3 to 5 years with safety. This is because of progesterone, which increases the risk of breast cancer. And in case of estrogen, where the hysterectomized patients, we can use for 7 years. But both estrogen and progesterone or estrogen, they need to be followed for 4 years. And stopping, we can stop the MHT either in a dose decreased manner or can be abrupt too. So the main thing which I wanted to show in this slide is the time since menopause. That is, window of opportunity within 10 years. We have to start the MHT as early as possible so that the benefits are achieved and there is a low risk if started early. And progesterone have to be given in adequate dose for to prevent endometrial hyperplasia and also endometrial carcinomas. And estrogen alone is given in hysterectomized women. And endometrial surveillance is not needed in low-risk asymptomatic women. And the main thing is the calcium, which is a foundation stone. It is in 99% of calcium is there in the bone. Many organs and tissues needed, like heart, skeletal muscle, nervous system and blood coagulation. When the woman reaches the menopause, the bones lose calcium, but it is deposited in the arteries. So it is more deposited in the circulation. And food plus calcium requirement is very important. And post-menopause, it is 100 milligrams per day. We need to give, we need to talk her in which food the calcium is more, that is in the yogurt, broccoli, fish, orange juice, etc. We need to tell them in which all foods the calcium is abundant. And the calcium preparations, when we come to it, we have always a doubt whether to start calcium carbonate, citrate, glucarate, or lactate. The calcium carbonate is the usually available preparation since a long time, and it contains 40% of elemental calcium, while citrate contains 21% of elemental calcium. So the important thing is smaller doses as 500 milligrams can only be absorbed. So we cannot just give a higher dose thinking that we should give 1500 at a time. So the carbonate is less expensive but requires acidic medium for absorption. But citrate is a more expensive one. It can be taken without food. On empty stomach, it can be taken along with the antacids, it can be taken. But only thing is, we have to give in more tablets. So we cannot prescribe along with the calcium, along with the other drugs. Liquid form of calcium is better. Citrate 25% better absorbed than carbonate. And we cannot give along with the phytate, oxalic acid contain food and medicines because this decreases the calcium absorption, and always calcium has tablets have to be maintained at the room temperature. And vitamin D is also important for skeletal and bone health. The sources are food supplements and also the sunlight, but we cannot just rely on the sunlight. We have to supplement in food also, and if required in tablet form. So the patients who are at risk of vitamin D deficiency are older adults, people who spend less time in sun, people who have a dark skin, and obese or very overweight patients, and skin concealing garments who use them, and also sunscreen lotions usage also, this decreases the absorption from the skin. And the vegans or vegetarians who have high phytate consumption, such as in chapatis. So at least 10 to 15 minutes between the 11 a.m. and 3 p.m. if we sit in the sunlight, that would be better for the normal level of vitamin D. The fatty fish, dairy, and other foods like fortified cereals, juices, they contain a lot of vitamin D. And the important thing is, egg yolk contains 44 international units of vitamin D. We see most of the women, like, they have only the egg white, thinking that it has only they need the protein. At the same time, they need to have the egg yolk, which has lots of vitamin D. So that we need to educate, not to just throw the yolk. And 800 to 1000 international units is the dose of vitamin D required by the menopausal woman. And best is weight-bearing exercise. When we talk of exercise, best is a weight-bearing exercise. So we have like osteogenic exercise is divided depending upon the osteogenic potential, like high estrogenic, moderately estrogenic, that is high estrogenic, like impact aerobics, basketball, etc., which the menopausal women cannot do. Moderate osteogenic, most of the menopausal women can do, like running, jogging, brisk walking, stair climbing, and resistance training. And low estrogenic is a leisure walking. And in case of previous fractures and all, they can also go for a leisure walking. And non-osteogenic is swimming and cycling. So the flexibility exercises are also important, like yoga, aerobics, and endurance exercises are walking and cycling. Strengthening exercises are the gym and weight training. So this is the schedule which need to tell to our menopausal women. The flexibility exercises every day, they need to go for 20 minutes, and maybe for 6 days also it is okay. The important thing is, what is the 333, that is 3 days in a week, 30 minutes brisk walk, and for 3 kilometers. This is endurance exercise. And in case of strengthening, 3 days a week, 30 minutes gym, or 3 group of muscles exercise. That is a strengthening exercise. So swimming is not a weight-bearing exercise, so it does not help in the bone health. But in case of kyphosis, which it prevents the further increase of kyphosis, so, and also increases the cardiopulmonary fitness. So then we can suggest to them. So the dietary prescription, we need to have a calorie count also, 60% carbohydrates, 20% protein, 20% fat. And protein intake should be 1.2 to 1.5 grams per kg per day. Healthy fats have to be taken, not the saturated fats. And omega-3 fatty acids should be taken like flax seeds, canola oil, walnuts, soya beans. They are very rich in omega-3 fatty acids. There should be a positive balance for omega-3 when compared to omega-6. Otherwise, again, it becomes like the bone strength will not be there. And fiber intake has to be increased for the fullness and also to prevent the extra calories. And salt has to be cut down, because whenever there is an increased intake of the salt, the calcium requirement increases. Whenever we cut down the salt, almost like calcium requirement decreases by about 160 milligrams. So we need to avoid the tinned food, pickles, fried snacks, etc. And no added sugar, as we all know. And a handy pound guide has to be used. That is, handful of vegetables and a thumb of fats and oils need to be taken instead of more of oils and cheese, etc. meat. And vitamin is also required, and this is a fat soluble vitamin. Mainly it reduces the vasomotor symptoms and also helps in bone health. Micronutrients, we all know that zinc, calcium, iron, magnesium, folic acid are all required, and fat soluble vitamins like A, D, E, K also should be taken. So salt has to be decreased. Oil 2 level tablespoons, not more than that, is needed. Fruits about 100 grams per day, vegetables 300 grams per day. That is 1:3 ratio fruits to vegetables to fruits. 8 glasses of water, add powdered flaxseed, cinnamon, fenugreek. All this helps in omega-3 fatty acids. So tea, coffee should be cut down, and dairy products about 600 ml of low-fat milk helps in bone building. And vitamin C rich fruits help in calcium absorption. And the alcohol should be in moderation, 30 ml a day. And we should discourage the crash diets, which causes a rebound weight gain, and there is it does not give any positivity towards the health. And phytoestrogens and isoflavones are a natural alternative to the hormonal replacement therapy. They increase the bone mineral density and improve hot flushes and vaginal dryness. And it is always better to maintain healthy weight. And whenever there is obesity, the exercise part of it decreases and the bone health decreases. So we have to counsel the patient not to increase in weight, but rather than to exercise properly, have food, diet, everything has to be explained. The other drug we need to know is the Tibolon. Tibolon either can be taken in 2.5 milligrams or 1.25 milligrams. It is equally effective, and it can be started only 1 year after menopause, and it has estrogenic action on the bone. That is, it helps in bone health, and it has progesteronic effect like on endometrium breast. So it is a very good drug which has a good effects, estrogenic effects, and whatever is bad regarding the progesterone, it acts as an anti-estrogen. So this is quite a good drug in case of bone health. And recent drug what FDA has approved is a bezodoxifene with ethinyl estradiol. It has been approved for vasomotor symptoms and osteoporosis. So it lowers the risk of uterine hyperplasia caused by the estrogen. So the main problem was with the progesteronic effects. So all this have been decreased by the bezodoxifene combination. And in clinical trials, it has shown that it has decreased the bone turnover and the bone loss. So it helps in prevention of osteoporosis. So we have to think about the window of opportunity whenever the postmenopausal woman comes. So the 10 years of postmenopause is considered as a window of opportunity. So we need to start the menopause hormonal therapy to prevent the rapid bone loss and to maintain the microstructural strength of the bones. So whenever we do oophorectomy, we need to, that is in premenopausal condition, whenever we have to do an oophorectomy, suppose in cases of malignant tumors, etc., we need to start MHT immediately. And we have seen many of our menopausal women in COVID, definitely they must have lost their bone health because of the steroids and anticoagulants. We have to definitely ask whenever a patient comes, did she suffer from it, whether she used steroids and anticoagulants. Maybe we need to get her DEXA done, see for the bone mineral density, and also plot her on the OSTA or on the FLAC scoring. So this is a logarithm showing which drug to be used That is mainly in osteoporosis. If the menopausal symptoms are there, we go for MHT or tibolone or bisphosphonates. When there are no menopausal symptoms, we can go for bisphosphonates or raloxifene. So in case of severe osteoporosis means they have a fragility fracture, then we can only go for teriparatide, calcitonin or denosumab. So osteoporosis is a silent disease, devastating disease. It can be prevented. So hence we need to talk to our patients, whether they have any backache, they have any problem, what is their family history, did she have fracture any time, what are the drugs she's been using, see for put it in the OSTA score or the FAD score, ask her to go for a DEXA scan, and then definitely we can bring down the fractures by about 40% in them. So thank you so much.
So nice presentation, Sushila. Any doubts? Ambaji garu, thank you for your good words, Sara Patnaik garu. Very nice to you and happy. Convey our wishes to Mahapatra garu. And Patnaik garu, are you using teriparatide? Are you there? Hepzibah?
F, I think.
Any experience with terapeptide?
No, I
Parathyrroid hormone.
personally used it, madam, but orthopedic, one of my friends, it was prescribed by orthopedician.
My colleague also took one dose, one course actually, but she is not happy. Not so much improvement, she says. Maybe watching purpose or
further fracture, madam. Maybe definitely
prevention.
Further fracture.
Whenever there is fracture, they definitely need parathyroid hormone.
Yeah.
Any doubts regarding all? Any questions are there?
The chat, I don't see anything, madam. It's not that. That's no. Actually, and something is very clear, they don't ask questions. Shall we wind up, madam? Shall I ask what of
Okay. Let us wind up.
Thank you, ma'am. Thank you so much for the
All the
opportunity.
speakers have done justice.
Yes, yes.
To the topics.
Yes. Confined, and they didn't give a clear-cut ideas. Ita?
Yes, ma'am. I thank the Chennai Menopause Society and the Vijayawada Menopause Society for such a wonderful topic on bone health. I thank the president, the chief guest, Dr. Shobana Mohandas. I thank the guest of honors, Dr. Hara Patnaik and Dr. Ambuja ma'am. I thank our president, Dr. Hepzibah ma'am. I thank Dr. Ramadevi ma'am, seeing you for the first time and happy to have you ma'am. And I thank all the, chairperson, Dr. T.K. Shanti Gunasingh ma'am. I thank the speakers, Dr. R. Divya, she is very vibrant. And Dr. Hema, you had given many beautiful tips. Thank you very much. Dr. Hepzibah ma'am, as usually, was rocking. And we have Dr. Sushila, who really had given us an elaborate and a beautiful picture of the treatment. Usually it is always very confusing, but thank you for a very beautiful presentation. Thank you all.
Thank you,
At last, last but not the least, I thank all the doctors who have attended the meeting, and they've made it as a grand success, and also the Shield who has partnered with us in this webinar. Thank you very much.
Thank you, ma'am.
Thank you all. Thank you all.
Thank you.
Thank you.
Thank you,